article this evening is looking at the treatment of bisphosphonate stress fractures, coming from a recent series of patients that we had at Sunshine with stress fractures and proximal femur on long-standing bisphosphonate treatment. This is from clinical orthopaedic and related research from July of this year. So just as a bit of background, bisphosphonates have been used more recently as first-line therapy in osteoporosis management. And this is based on strong evidence from a few trials, particularly a large randomised multi-centre study looking at the reduction of fractures in the elderly population, where over 4,000 patients showed 36% reduction in hip fractures and 44% reduction in vertebral fractures. Of note, this was over a 4-year follow-up period, and subsequent studies of the same group of patients showed that there was no significant improvement in fracture reduction risk beyond the 5-year mark in keeping alendronate going. Bisphosphonates can be divided into nitrogen and non-nitrogen containing the mechanism of action, and the one that we use mostly is in the nitrogen containing group. So the non-nitrogen containing include atidronate and clodronate, and they work by binding to the mineral phase of bone and subsequently are absorbed by osteoclasts and inhibit the ongoing osteoclast function. The nitrogen containing, including zoledronic acid, alendronate and resedronate, which we see more often, inhibit the intracellular pathways and hence cause apoptosis of the osteoclasts. There's also some suggestion of anti-tumour activity or synergistic action with anti-cancer agents. But more recently, there's been evidence of over-suppression of bone causing brittleness from this medication. And as we've all seen, complications from bisphosphonate, long-term bisphosphonate use has been attributed to subtrochanteric and diaphyseal femoral fractures. So these stress fractures have been defined as transverse with unicortical breaking and hypertrophy of the diaphyseal cortex. They may be identified with MRI, but the majority are picked up on plain X-ray and have only really been connected with alendronate use. There hasn't been research into the other types of bisphosphonates to date. The actual fracture risk, however, is still unclear. So a NEDM article from last year looked at the outcomes from those previous trials that I discussed of long-term bisphosphonate use, and they found out of 14,000 patients, only 12 had the relevant fractures that we see, which gave an outcome of 2.3 per 10,000 having these type of fractures. Overall, we had an underpowered outcome and there was no significant increase in fracture risk, but there were quite wide confidence intervals from those studies. The mechanism of these type of fractures is quite unclear, but it's thought to be due to decreased bone trauma, bone turnover, microtrauma and subsequent poor healing of the insufficiency fracture. The options for management include non-operative, so protective weight bearing and or operative management. And this is where this study comes in, where a study from a group in Boston looked at the likelihood of non-operatively treated fractures, bisphosphonate-associated stress fractures, progressing to completion, and also whether prophylactic fixation would reduce the length of hospital stay. This was a retrospective review where they collected patients who presented with femoral fractures from 2002 to 2009 in 2 different trauma centres. All the non-displaced proximal stress fractures as well as complete fractures were included in the study, and the patients were recruited over the age of 50 because of the greater likelihood of being on bisphosphonates. They excluded patients who had a high energy mechanism, malignancy, or any other type of proximal femoral fractures that don't really fit with our bisphosphonate picture, and got a total of 613 patients that fitted this criteria. From this, only 40 fractures fitted with the X-ray characteristics that I discussed before, or that they actually had a complete transverse fracture, as well as a documented history of bisphosphonate use. This is a table showing the demographics of the patients. So all of the patients were female, and the majority had been on alendronate, but there were a few on the other types of non-nitrogen containing bisphosphonates, and the majority had over 5 years of use of bisphosphonates. 28 of the 40 patients that were identified had complete fractures with no previous history of a known stress fracture. They'd all fallen from a standing height and nothing beyond that. And no one had bilateral fractures at the same time, although some of them were included in the group that had incomplete stress fractures. 12 of the 40 had identified stress fractures, so that didn't complete incomplete fractures, and these were randomised to be treated into either non-operative or operative treatment. There was overall no loss to follow-up, and they had a minimum of 12 months follow-up in the period. So the study defined their non-operative management as partial weight bearing with a crutch until the resolution of pain and radiographic documentation of disappearance of the fracture. And they had to be actively followed up and monitored for outcomes. The operative group were those that had complete fractures, or the randomised group that from the partial femoral fractures. And these were treated with an intramedullary nail and weight bearing from day one post-op. So just going through the results, as I said, 28 out of 40 had complete fractures from the start, and they were managed operatively. And of the 12 that had stress fractures, 6 were treated non-operatively and 6 operatively. Of the group that had attempted non-operative treatment, 5 had failed and went on to have completed fractures, and only 1 had successful treatment in the non-operative group. With regards to hospital length of stay, in the group that had femoral stress fractures that were treated non-operatively, they had an average of 6 days of hospital stay, in those that had ended up failing non-operative treatment. On average, they presented with a completed fracture at 10 months, and there was that 1 out of the 6 that didn't progress. In the group that had prophylactic nailing, so the 6 that had prophylactic nailing only had a hospital stay of 3.7 days, and this was statistically significantly different from the group that had progressed. And finally, the group that presented with complete fractures had a hospital stay of 6 days, which was again longer than the prophylactic nailing group. The study also assessed union and overall had quite high rates of union in all the groups, with 96% in the completed stress fracture group. And lastly, complications. They had no complications in the group that had prophylactic nailing, but in those that had a complete fracture, there was 1 patient who developed non-union and 2 that needed further metal wear removal. There were no infections in this study. Statistical analysis included the student t-test for the hospital length of stay, and further analysis for the normality of the data. So just to go through the article, overall this is one of the few articles that actually presents some evidence for prophylactic nailing. They did have a prolonged recruitment period and no loss to follow-up, but this is actually one of the disadvantages, is that it was unclear as to who actually went through all the x-rays and found out and diagnosed the bisphosphonate-related fractures. The disadvantages are that it was retrospective, and therefore we had some data missing, so the duration of bisphosphonate use wasn't documented in all the patients. It was a very small sample size, and it of course was not randomised. Future research, I think, from this study would require a multi-centre trial because of the low numbers in this type of injury, as well as cost analysis for comparison between prophylactic nailing and an actual admission post-fracture, as well as assessment of other types of bisphosphonates. In comparison to another study that I found was a retrospective review of 14 undisplaced bisphosphonate stress fractures. So of the 14, they had 5 that went on to progress to need surgical fixation, but 5 had intractable pain that needed surgical fixation rather than an actual completion of the fracture. And in this study, they had a lower rate of fracture completion, but overall smaller numbers. So in conclusion, there's limited evidence for the outcomes of bisphosphonate-related stress fractures, but this retrospective review highlights the high risk of progression to complete fracture, the shorter length of hospital stay with prophylactic nailing, and has the potential to improve patient outcomes with reduced pain and post-operative complications potentially.